Good evening, everybody. Thank you so much for joining us tonight. My name is Ben Berry. I am a PhD candidate in the Department of Health Education and Behavior, and it is my great honor to introduce Dr. Keith Humphreys, the Esserting Memorial Professor in Psychiatry and Behavioral Sciences at Stanford University. Dr. Humphreys, welcome. Thank you so much for joining us tonight.
Thanks. I'm really happy to be at University of Florida today.
Wonderful. So I guess to get us started, can you talk a little bit about some of the influences earlier in your life that led you to study the addictions broadly, and some of the influences that led you to work on the opiate crisis specifically?
Well, I actually got into the addiction field pretty accidentally. I was a college student and I was majoring in psychology, and I didn't know what kind of psychology I was going to do. And I was flipping burgers at a fast food joint to make ends meet, and I was making $3.35 an hour. And a friend of mine came in and she said, I'm graduating and I have this job in the medical school and I'm working for a professor and he needs somebody to get articles for him, and would you want to do that? And I said, well, what does it pay? And she said, $4 an hour. And it's a study of addiction. And I said, for $4 an hour, I'll study anything. And so I got rid of my Wendy's outfit and went over to psychiatry, and I did this job. And so it was a chance thing that's how I started. But why did I stay in it is probably more important. And it's because addiction captures everything about the human experience. If you work with people who are addicted clinically, you see hope, frustration, love, struggles with control, death, recovery, meaning, families torn apart, families coming back together. It's all there. And then it's also just incredibly fascinating as a scientific phenomena too. You know, it's something, you know, we've evolved to live and survive, and yet we are vulnerable to substances that change how we make decisions, change how we conduct ourselves, and we will start consuming drugs in preference to things like food, which we actually do need to survive. Right. And so those two things, the human drama and the scientific mystery, is why a chance encounter really launched me on a career I've been on for 30 years.
Wow, that's incredible. So kind of transitioning, are you able to comment on kind of the impact of the opioid crisis, and does it come along any demographic lines, or are there any subpopulations that are particularly hit hard by this crisis?
So there's multiple waves to the opioid crisis. So it starts in the 90s as prescription opioid companies, like Purdue Pharma is probably the most famous one, begin aggressively promoting their products and telling a lot of doctors who are not that well trained in pain medicine or in addiction medicine, don't worry, you can keep raising the dose, nothing bad will happen, addiction is extremely rare, and so on. So prescribing goes up almost 400%, and a huge number of people overdose on prescription opioids and or get addicted to them. That's wave one. That wave was disproportionately white people, a lot of rural people, but also a lot of middle-class suburbanites. Then we had a second wave, which was the arrival of heroin, and some of that was consumed by people who were already addicted to prescription opioids. But once heroin markets sort of fired up again, we also had people going directly into heroin markets. And then more recently, heroin has been infiltrated with another very strong opioid called fentanyl. And those are the three waves. The second and third waves have been much more universal. So now the death rates among rural people, suburban people, and urban people are way more similar. The rates across different groups are way more similar than they were when the whole thing started. I mean, this has become everybody's crisis. There are individual groups that are better off. I mean, if the middle-aged adults and early adults have probably been hit the hardest. In cities, the death rate is a little lower, but not because people are using less, just because they're a little closer to maybe ambulance services and hospitals and things like that. So this has now just become something that touches the whole fabric of American life.
Interesting. Are there any sort of social or cultural factors that we need to be mindful of when we think about some different strategies or effective strategies for combating the opioid crisis? I mean, it doesn't sound like a one-size-fits-all here for this particular problem.
No, it's not. I mean, I think from a diversity viewpoint, one of the most important things to realize is how we think about race and culture affects how we think about drugs. And through the history of this country, when a group that is discriminated against, like think workers from China out in the West building the railroads, Mexican farm workers coming up in the 1930s, African Americans in the 60s. Now, respectively in those groups, yeah, there were some people who used opioids, there were some people who used cannabis, there were some people who used heroin, but because those groups were all subject to discrimination, they were labeled as the source of evil. Their drug use wasn't a health problem, it was that they were bad people. They were shiftless and lazy and pleasure-seeking, and what they needed was discipline. And that usually meant punishment. I mean, locking them up, arresting them, and so on. If you look at this epidemic, which starts in a far more white population, a lot of middle class, it is striking how much less of that punitive view has come out. And I'm not saying I want that punitive view back. I think that punitive view is destructive and unfair. But it's entirely understandable why I started my career in Detroit, working on the very poor parts of the city, African Americans during crack cocaine. A lot of those people from those days are very bitter to see the more compassionate response to the opioid epidemic, and they wonder, where was that when we were all going to jail in the 1980s over crack cocaine? And I think there's multiple reasons for that, but the biggest one has to do with racism.
And do you see that changing as we go forward, or you still kind of see the same cycle repeating itself?
Well, you know, the lesson I guess we'll know more about whether we've grown up or not the next time an epidemic doesn't start with a heavy white middle class, representation. And I hope we will do a better job than we did, with crack cocaine. Or frankly, to be fair, the methamphetamine epidemic was mostly white, but that was extremely poor people in rural areas, and we were again very punitive about that. I think there has been progress. I know there has been progress in America in general of understanding addiction as a health problem, and that is a good thing. But it won't be here until everybody gets the benefits of that understanding. And I think we have yet to demonstrate that. Maybe it's the next epidemic that will tell if we've truly been able to give everyone our compassion and not just part of the population.
Certainly. Can you comment on any particular barriers towards implementing effective strategies? And is there anything that we can do, whether it's as community members, as people in academia, or who do research, who can help kind of address those barriers and move past them?
Yeah, I mean, this is a huge problem. I mean, the rate of death from opioids and drug addiction generally has no parallel in my lifetime. This is worse than AIDS, if you can believe that, in terms of the rate of people dying. You'd have to go back to the late 1950s when we had what was called the Asian flu epidemic of 1957, 1958, to have where Americans were dying at such an incredible rate. So it's going to be very hard to turn this around, even if we do everything right, and we're not doing everything right. Some of these things are underfunded. Oftentimes they're poorly implemented. Sometimes communities don't want them. There's still a lot of people who are extremely angry, hostile towards addicted people. They don't want to see a treatment program. They want to see, tough responses and not health responses. So there's a lot of barriers there, but there's also a lot of hope. There's an enormous number of people engaged. And to answer the second part of your question, yes, absolutely. Everyone can get engaged on this problem. There really is something that all of us can be doing, whether that's demanding of our elected officials that they be responsive, but also the way we treat each other. Almost everyone now knows a family that's been affected, and if we reach out, with compassion rather than judgment and blame, that can only be a good thing.
Yeah, I agree. And you touched on this shortly ago, just kind of on the pejorative nature of the way we've tackled this problem. What are some of the biggest or most common misconceptions about the opioid crisis that would be beneficial for everyone to know?
That people who are addicted to opioids are just shiftless, pleasure-seeking people. First off, a huge number of them got addicted following their doctor's advice. They weren't looking to use a drug in the first place. Long-term opioid use is not pleasant. Yes, you get a big high. That's why people take them early on. But it's really a misery being addicted to heroin. You're far more misery than you do joy. And really what is happening is you're waking up every day at sort of -5, and the opioids maybe bring you back to 0. But it's the pleasure drops, and it's just kind of a gray and difficult life. That's a big myth. Probably another big myth is that you can't recover. That because of all these deaths, it's easy to feel despairing.
hopeless.
But yeah. But the truth is, we have multiple FDA-approved medications that really work. We have terrific behavioral therapies, psychotherapies that work. There are people who get better also without the treatment system. There's people who get better in 12-step mutual help organizations, or they are able to, maybe they get into a different life situation with different rewards of, they get a really good job, they get some friends who love them. People do pull out of this problem and live, and I know people who are very successful and happy who've had problems with opioids. So it can happen, and it's important not to be despairing, because once we start doing that, we actually make the problem worse, because it comes out in our interactions, our behavior when we talk to people who are addicted to opioids, that we don't have any faith that they can get better, but they can.
Right. Yeah, I think that message of hope is really powerful and can impact a lot of people's lives. Awesome. Well, Dr. Humphreys, thank you so much. That's all the time we have for today. I just want to give one last final reminder. Tomorrow is the DK Stanley Lecture. Tomorrow, March 19th at 9:30 a.m. in the Florida Gym. Again, Dr. Humphreys, thank you so much. It's been a pleasure.
Thank you, Dan. Really good to meet you.